Hello everyone. Today we are going to discuss about bed sore. Bed sore is nothing but tissue necrosis or ulceration which is occurring because of continuous external pressure. So why is this bed sore is happening? So coming to pathophysiology, if this is a part of skin and this is epidermis and this is dermis. Epidermis do not have any blood supply on its own. Dermis will be having blood vessels and epidermis will receive nutrition from dermis. So if patient is lying on a same position or posture for a longer duration of time, especially over bony prominences, the skin will be compressed between the bony prominences and the floor. So that external pressure will cause compression of capillaries. This may look like this. So capillaries are compressed. So epidermis won't be getting any nutrition. So it will undergo necrosis or ulceration. So this is called as pressure sore or bed sore. There are few other names for bed sores. These are also called pressure sores, decubitus ulcer, or trophic ulcer, since they are occurring over pressure bearing areas. So coming to risk factors, so the major risk factor what we saw here is lying on the same position for a long duration of time. So that is the major risk factor. Second risk factor is already the capillaries are occluded. So if patient is having any malnutrition or anemia, this will be worsened. Since he is not getting any nutrition, the skin will die. So the other risk factors are anemia, undernutrition. Moisture is a very big risk factor. Since most of these patients are bed bound, their linen may get contaminated by urine or feces. So this moisture will act as source of infection and it will contaminate the wound. So this may cause sepsis and this will prevent wound healing. Bed sores are usually seen in patients with neurological diseases such as paraplegia, tabes dorsalis, and syringomyelia, etc. And so many patients. So these patients either they can't move or they can't feel any sensations over their back. So this may progress to bed sore. Since these ulcers are occurring in a patient with neurological disease, these are also called neuropathic ulcers. So coming to common sites where bed sores are occurring, most common site being ischial tuberosity, followed by greater trochanter, followed by sacrum, followed by malleoli, and lastly occiput. So this is an image of bed sore. Image A is showing a bed sore at the greater trochanter area. Image B is showing a bed sore at ischial tuberosity, and image C shows a bed sore at sacrum. So coming to clinical features, this patient will present to us with ulceration. Usually patient will not complain of anything because this will be painless. Usually the patient attenders will see this and will take the patient to us. So there will be a painless ulcer over pressure bearing areas, most commonly being ischial tuberosity followed by greater trochanter. So this ulcer will be painless and it will be having classic punched out edges. And base is formed by bone or muscle, whatever the structure underlying may be. So coming to staging of bedsore, stage 1, 2, 3 and 4. In stage 1, there will be only non-blanching erythema. There is no ulcer at all. So there will be non-blanching erythema. We will see redness over the area, but that will be non-blanchable. That means if we apply pressure over that area, that area will not turn into pale. So this is non-blanching. Stage 1 is also called as early superficial ulcer. In stage 2, there will be involvement of epidermis and a part of dermis. So this will be partial thickness ulcer. Stage 2 is also called as early deep ulcer. In stage 3, epidermis is involved, complete dermis is involved, and a part of subcutaneous tissue is involved. Muscles, tendons or bones are not involved in this stage. This stage is also called as late superficial ulcer. And finally, in stage 4, epidermis, dermis and subcutaneous tissue is involved. Along with these, whatever the structure underlying might be involved. That might be tendon or muscle or bone. So it will be stage 3 plus muscle or tendon or bone. This is also called late deep ulcer. Let's look at an image. So these are the stages of pressure ulcer. In stage 1, only epidermis is involved. That too, there is no ulcer at all. There will be only erythema. In stage 2, epidermis and dermis are involved. A part of dermis, but not, which is why it is called partial thickness ulcer. In stage 3, epidermis and full thickness of dermis and part of subcutaneous tissue is involved. In stage 4, epidermis, dermis, subcutaneous tissue and muscle or bone. Underlying tissues are involved. So this is stage 4. Bedsores occur in 5% of hospitalized patients. And this is preventable by taking proper care of the patient, by keeping him dry, by keeping his clothing dry, and by changing his position frequently. And ensuring proper nutrition, we will prevent bedsores happening in that patient. Coming to management, we should start with conservative management, and only when it fails, we should opt for surgical methods. So in conservative methods, we need to change position of that patient regularly so that continuous pressure won't be there for the necrosis to happen. That is, if the patient is bedbound, we should change a position of that patient every second hourly. But if he is wheelchair bound, he should move, or he should stand up, or for at least 10 seconds for every 10 minutes. Instead of a normal mattress, we should use a pressure dispersion foam mattress and air bed or water bed. we should ensure that his linen, his clothing are moisture free. We need to correct his nutrition. We need to supplement him with good nutritive elements, and we need to correct his anemia. He can be kept dry by use of talcum powders, by having proper hygiene, by urinary and fecal diversion, so that urine and feces won't contaminate his linen. And we will use antibiotics if we suspect infection. If patient is not responding to these conservative methods, we will go for surgical methods. In surgical methods, we will do debridement of that wound, and we need to do dressing. In dressing, we should apply more padding, and we can also opt for vacuum assisted closure. We should avoid primary closure and grafting. We should avoid primary closure and grafting because these are more likely to fail in these patients. So rather than going for primary closure and grafting, we should go for large myocutaneous flaps. For example, tensor fascial atta flap, which is based on a lateral circumflex femoral artery, will be used for closing defects caused by bed sores. Thank you.